Like, everybody's body is so, so different. Don't go into it and be like, well, my friend, she waited until she was 5 centimeters for her epidural. Like, I want to try and make it 5 centimeters. Like, who cares? Get the epidural when you want to get it. If you want to push it off a little bit longer, fine, but do not compare your labor to anybody else's because it is so unique to everybody.
Hello, and welcome back to another episode of the Birth Lounge podcast. Before we dive into today's episode, I wanted to talk to you really quick about one of the best resources that you can have right in your back pocket so that you can have an informed and confident birth. A little bit of real talk is that you absolutely can have a positive hospital birth. Despite what you see on the internet and despite all of the viral birth trauma stories that go crazy wild on Instagram and TikTok and all the social media platforms, you can have a good, positive, uplifting, empowering, joyful hospital birth, but not if you're walking into the hospital system blind to how the system actually works. And that's actually exactly why I created the Birth Lounge app. It's like having me, hello, in your back pocket, your doula, your evidence-based hype woman, and your birth translator all rolled into one affordable, accessible app. Inside the Birth Lounge app, you're going to find bite-sized videos that teach you exactly how to avoid unnecessary interventions, how to advocate for yourself confidently, but also respectfully. Remember, I want to build this collaborative partnership between you and your care team where you are the decision maker, but you also are not coming to your care team disrespectfully or furthering that divide that we all feel. And I'm going to teach you how you can actually enjoy your birth experience. We're talking step-by-step guidance through every stage of labor. I'm going to teach you my secret sauce to pushing techniques that will not only help reduce your chances of tearing, lessen the time that you push, but also protect your pelvic floor. And inside the app, you're going to find scripts for exactly what you can say to your provider when you're offered something that may not feel aligned to you, or how to ask questions if what's being offered to you makes you feel a little unsure. Plus, there's postpartum prep, partner support guides, and even a section to help you with recovery so that you can thrive after birth, because it doesn't stop once your baby's out, right? And I think my favorite part of providing everybody with an app is that the access is all straight from your phone. You don't have to get on the internet. You don't have to log into a web address. You don't have to keep a book in your purse or listen to an hour-long podcast. It's literally right there in digestible, quick, easy reads, no fluff, no fear tactics, just real evidence-based education, all facts, and it's all linked for you in the app. I legitimately designed this app to give you peace of mind and to help you put together a plan that actually works. I'm doing more than what your typical childbirth education app does. I'm not just teaching you what your options are, which anybody out there on the internet streets, they can do that. What I'm teaching you is not only your options, but how do you actually achieve the birth that you want once you know what your options are? How do you actually say no thank you to a 39-week induction when you have no medical necessity for it and you really are dedicated to spontaneous labor? How do you say I'd rather go with this alternative instead of X, Y, and Z? How do you truly decline Pitocin when there's no real need for it and the hospital system is simply trying to speed up your labor? So whenever you're ready to ditch the fear and you want to walk into labor feeling confident, download the Birth Lounge app today. It's available everywhere that you download apps, regardless of what kind of phone you have, because birth doesn't have to be traumatic. Not when you know how to navigate it. Visit your respective app store and download the Birth Lounge app today. I cannot wait to see you in there. All right, you guys, today's episode may be one of the most sought after conversations I have ever had on the show. We're talking all about epidurals. How many women get an epidural? What are the medications that are used in an epidural? What's the placement process for an epidural look like? And how many of those epidurals actually fail? And then if they do fail and you're one of those people who unfortunately have an epidural that doesn't work, what are your options beyond that? I'm so stoked to have my friend Marissa Mulder on the show. She's a CRNA, and if you don't know what that is, it's a little bit different than an anesthesiologist. A CRNA is a certified registered nurse anesthetist. This is an advanced practice registered nurse who administers anesthesia to patients. Whereas an anesthesiologist is actually an MD or a medical doctor. They're a physician. Now, you may know Marissa from her Instagram, Sassy Anesthesia, which is how I found her and began to start loving her so much. She also just had her own baby, which I think is even more fun. She and I got to geek out so deeply about epidurals in this episode. And of course, in true hee-hee fashion, I'm going to press her on all the hard questions that you guys ask me, and I give you my best opinion, but I think having insight from someone actually inside the hospital is really cool. So we're going to talk about why would an anesthesiologist not let a partner stay in the room when you are having an epidural placed. We're also going to talk about turning your epidural up and down and off if you regret it. And then also we're going to talk about continuous monitoring. Can you have an epidural and also decline continuous monitoring? And what are the risks that you're taking on if you do decline that? I also want to know things like what is an epidural versus a spinal, and in which situations would one be more appropriate than the other? Of course, we're diving into the risk and the benefits because, duh, that's like the whole basis of what I do. But we're also going to talk about the other more controversial things like, does an epidural actually transfer to your baby through the placenta? Can it slow down labor? Will it give you long-term back pain? And does that epidural needle actually stay in your back? You know what I say about birth plans. I think that you should truly plan for every single situation. So regardless of what your pain relief plan is in labor, I think this is a must-listen episode for everybody. If you're planning for an epidural, then duh, this is a no-brainer. And if you are planning for unmedicated, I still think that it is super important for you to understand not only what an epidural is, but how it may impact your labor, because what if you get in the situation where you decide to change your mind and get an epidural? You hear me say this all the time, but one of the best ways that we can prevent birth trauma is making sure that we are prepared for not only the things that we think are going to happen, but also the rare occasions that we think may not happen. Epidural use is widespread, and so many women choose to have an epidural. And also, anesthesiologists and CRNA skills vary widely. So do hospital policies and protocols, which all lends its hand to the type of experience that you have when getting an epidural. This episode is really one that is going to help you understand what your options are in an unbiased, non-judgmental way. So without further ado, Marissa, welcome to the show.
Hi.
Hi, I'm so excited to have you on. Obviously, we have been Instagram friends for a little bit, and I've learned a lot from your page, and you just had a baby of your own. And I also think that this is a conversation that a lot of people want to have the education about. But, I think that, well, like with anything, there can be a lot of misinformation online where it can feel very scary, or people choose the epidural because they think it's their only option, Or when you choose the epidural, sometimes you walk away feeling like, well, I wasn't really briefed on, I didn't really like get a transparent discussion on like what the risk and benefits were, what the pros and cons, like what was the placement going to be like, and there was no space for me to ask questions. And so that's what I'm hoping that this episode can be about. I just want people to have a space where they can get transparent information, they can have a conversation in a space that is not like in a rush or they're in so much pain where they can't take in information. I want them to be able to have this information and be able to go into their providers while they're still pregnant and say, like, hey, I'd love to have a discussion about this, especially because some things are going to be dependent on where you give birth in the facility protocols. You know, it's going to be very specific to that. So, I think a good place for us to start is maybe laying the foundation, the groundwork of just some simple statistics. How many women in the US get an epidural each year, and how often do we see those epidurals maybe not work or be what is commonly referred to as a failed epidural?
So, in regards to about an average for epidural insertions for labor in the US, I would say about maybe 75% of women do choose to use an epidural during labor. And in regards to a failed epidural, I think the definition of a failed epidural will probably vary as well. From what I've seen, it's about 23%, but in that regard, I think there could probably include some women that have maybe some aspect of pain relief and maybe didn't get the amount of pain relief that they were looking for. So I feel like that could be very suggestive or subjective. And we can go into that as well and kind of how we can control the amount of pain medication that you get and pain control that you can get with an epidural as well.
Yeah, I'd love that. I guess I have a question before we dive into that is when you're talking about women who kind of have coverage but kind of not, are you referring to what we kind of call like windows or they have like partial coverage but they still have like that breakthrough pain maybe on one side or in the hip or in one part of their back? Is that what we're referring to?
Yes.
Mm,
Yeah, so it could be several different reasons. So one of them would be anatomical. Some
okay.
people's epidural spaces, the catheter can just go certain directions and only give coverage on half of the body or not as high. It could be dose dependent, where that's a really easy fix, where we can come in and we can just adjust the rate of your epidural. Maybe we need it to go up a little bit higher. And it could also be very positional. And that could mean maybe you're just laying on one side and that epidural medication might only numb that side of the body because of the way that you're positioned. And so that could be also a really easy fix because that means we just maybe turn you to the other side or we lay you on your back, kind of get that coverage throughout the body and not just on that one area. So several different kind of aspects in a good or successful epidural.
Now, one thing I've heard as a doula over the years is once an epidural is placed, it's really common for nurses or providers. Funny enough, this never comes from the anesthesiologist, but they will often tell people, like, okay, you need to lie flat for like X amount of time. Is that true? Or is it possible that we could also like kind of sit up in maybe like a throne position, or we might be able to sit up and, I don't know, brush our hair, put on some lotion, reapply our chapstick, get comfortable again now that we've kind of like gotten comfortable with the epidural.
Yes, and I feel like I'm going to say this a lot today
Okay.
is what we do is I feel like very provider dependent. So there will
Okay.
be some providers that is their standard of care. They want you to lie flat. The reason for that is the epidural medication is almost kind of weighted. And so when you're laying flat, the point is to kind of raise that medication up a little bit to get a great amount of coverage as high as you want. Now, with that, you almost have to be careful because if you lie flat for too long or if there's a big bolus of medication, it could kind of come up and that's where you'll start to feel those women complain like I can't breathe, etc., which we can talk about that as well, but the sensation isn't that you can't breathe, but your body thinks that it can't breathe because it's numb. But I have also done spinals and epidurals on women and never had them really lay flat, and I don't ever really have issues with that either. And again, it's going to be, I think, patient dependent and anatomical because some women they might need to lay flat. It's all about experimenting with the comfort of the epidural for sure.
Yeah, okay, dive into that feeling of like I can't breathe because there's obviously some fear around the numbness because if you've never experienced anything like that before, I mean you there are people out there having babies that have never had any sort of surgery. They maybe have never even had dental work before, which is some light numbness, right? It comes back quite quickly. So if you've never experienced anything like that, it can certainly be anxiety provoking and you often have people have questions about like am I going to get feeling back in my legs, and I'm like yes, definitely you will certainly have that return to you, but the feeling of like I can't breathe must be even more anxiety provoking. That actually must feel pretty terrifying.
100%. And it's so interesting because that actually happened to me.
Oh.
And I can't even tell you how many times I have told that to other patients. And I've just been like, we're just taught that in school. Like, unless you've lived through it, you can't really apply that kind of feeling. But we've always been trained, like sometimes women will feel it. It's a little bit high. It numbs that area to the diaphragm to where your body thinks that it can't breathe. But really, it's just the body that can't sense its diaphragm anymore. And so the body freaks out. It's like, where is my diaphragm? I can't feel it. It's not, I can't feel that movement. Something's wrong. And then you start to panic. So even for me, when he first dosed my epidural, I'm pretty short. So I think it just went a little bit too high. And right away, I was just like, oh my gosh, like this is what those women are talking about. Like, this is horrifying. And I had to even talk myself down quite a bit and be like, Marissa, you know that you're fine. You know that you're breathing right now, because that's what I tell my patients, you're breathing right now. Your body knows to breathe. Your tidal volumes haven't changed at all. It just feels like that you can't breathe. You can only say that so much before you're like, turn down the damn med. But it like he had to come in right away and turn mine down. But it is very interesting how your body's perception totally changes with an epidural.
Now, is that based on placement, whether your epidural was actually physically placed too high or the dosage, like what you talked about in someone of maybe a shorter stature, just having too much of an initial dose, or maybe the bolus that you received was too
Mhm.
much and it rose too much in your body?
Yep, dosage.
Wow. Okay, so are all epidurals placed in the same exact spot on every spine?
Almost everyone. So the way that we kind of decide to place an epidural is we feel the top of your hips. And so we know that everyone's top of their hips is the L3, L4 interspace. That's how we know. So we know that the spinal cord ends at the level of L1. And so that's how we make sure, and we can bust that myth right now, that your chances of paralysis with an epidural are so low because we know that we're several levels below where the spinal cord ends. We know that it ends at L1 and we're inserting at L3, L4. And if not, sometimes we'll go down a level to L4, L5. So we know that we're not anywhere near that end of that spinal cord. And basically, like you said, yeah, almost everybody is at those two inner spaces.
Okay, now what about long-term back pain? Because that's something that on the internet you hear a lot of women will say, like, I never had back pain. I got an epidural. I now blame my epidural. What does the data say about that kind of correlation or association between those two things?
So the data overall, like what we learned in anesthesia school, is they do not cause any long-term back pain.
Okay.
Now, I will say the answer to that question is, in my opinion, I feel like once we numb that area of the body, you're going to sometimes be moved or move in a way that is unnatural. So you might be stretching, especially if you're put into stirrups, if you're on your side and someone's holding your leg. If you can't feel that, your body doesn't have the sensation to where you're stretching so much that your body's telling you to stop, right? So if somebody is kind of pulling your legs like all the way, your knees are at your ears because somebody's helping you and you can't feel anything, you could be stretching, that obturator nerve, your sciatic nerve. And that's where I feel like some people might have some sort of like kind of that back pain or the sciatica afterwards, given like pregnancy itself, like you're going to have like that there's that lower back pain anyways. But I think in my opinion, that could be some of the reasons why people end up with, some maybe longer term-ish back pain is because of that unnatural movement from just not feeling it.
Leave it to me to always find the gaps in healthcare, but this just kind of triggered me to think like maybe we should be including some level of physical PT. I mean, PFPT, duh, but physical PT or chiropractic care in that package of maternal care
Of
post birth.
course.
Like maybe for the first 90 days, 6 months, 12 months, you have access to either a PT or a chiropractor to just evaluate your lower back from the changes that your body went through in labor.
Oh yeah, I saw a chiropractor maybe in my third trimester every 2 weeks.
Okay.
So I loved the chiropractor. I was a little nervous up front, but they do amazing work. I
Yeah,
love my
yeah.
chiropractor.
Chiropractic care is a staple in our household. My husband goes, I
Yes.
go, our dog goes.
I
So
love
we
it.
we all go, you guys.
It's big in babies now too.
Yeah,
They're bringing babies now.
absolutely. Yeah, I'm a big believer that babies, they don't always need necessarily long-term care, and I'm sure the chiropractors out there probably want to crucify me for saying that, but I am a big believer in what I call like a birth unraveling. Like if you just go get that initial check, your baby goes through that corkscrew movement. They're dropping and they're descending and they're rotating. They are being squeezed in that vaginal canal. They spend hours being squeezed by contractions. If you have Pitocin, it could be even sometimes a more intense ride for your baby. And then, depending on how long you push, kind of dictates how long they hung out in that vaginal canal. If you didn't push long and they kind of rocketed out of you, that has its own impacts on their spinal cord, their body, their nervous system. So I'm just a big fan of what I call the birth like unraveling, and it just kind of puts them back in the neutral state. But yeah, no, I love, love, love chiropractic care. Okay, along the lines of placement, I did not know we were placing it at pretty much the same place on every human. That is really cool. I think it would be helpful for our listeners to hear, what does the actual placement look like? So step us through from the very beginning. You say, I want an epidural. Someone should brief you on, the pros and cons, the risk and benefits. You sign saying, yes, I'm okay with that. Your anesthesiologist comes in. Now what?
Okay. And you bring up a great point is talking about the epidural before it's placed. So I want the listeners to keep this in mind. This is not a conversation that you necessarily want to have when you are in excruciating pain. Have this conversation with somebody before, or at least do your research before you've come to the decision of whether or not you want an epidural. Because if you really truly want those answers at that time, you're not really going to be paying attention. You're not going to really care. And if this is something that's really important to you, where if you're really on the fence right now, make sure you do ask those questions. What are the pros and cons? And talk to your OB about it. It might be hard to get a hold of anesthesia from your OB, but I'm sure that you can make it work if you really did have some questions or do even some Google research, etc. Because this is something that is really important and it does take some time. So in most facilities, we usually do like a fluid bolus before we get your epidural. So that is something to keep in mind as well, is that once you decide on getting that epidural, you are not getting that epidural right away. And depending on the facility, it could be a very busy facility. That could mean that you might have an hour and a half. It could mean 10 minutes. I think for me, gosh, I don't remember. Like all of labor is such a blackout. I feel like it was very quick for me. Totally depends, but some hospitals they only have one anesthesia provider and that anesthesia provider could be in a crash C-section. They could be, in an epidural, four women ahead of you. You don't know where you're going to be in line. I've done epidurals for facilities that I've had like 13 epidurals in several hours. So it totally depends on what kind of hospital. And that is a question that you could ask your OB, how long about at this hospital that I'm going to deliver at, am I going to have to wait to get an epidural about average? Obviously, every situation is different, but it is something to kind of keep in mind if you are planning on possibly incorporating that into your labor, because I know several people that they waited until the last minute and they were in excruciating pain for like a couple of hours. So just something to keep in mind. With that being said, you're finally ready for the epidural. You're like, okay, obviously, most of the time you've got your IV in. If you've decided to not have an IV for your labor, plans have changed. You want to get an epidural now. Most providers are going to want to make sure that you have an IV in case of emergency. Epidurals can sometimes drop your blood pressure, and it is nice to be able to treat that pretty quickly because drop in your blood pressure means that you're also not getting as much blood flow to your baby. Exactly. So that is something that we want to kind of rapidly treat. We don't want to just be, fiddling around with an IV after we've got the epidural in. Maybe you're a difficult stick, just something that we don't really want to deal with. And I feel like most anesthesia providers would probably want an IV prior to your epidural. After the IV is in, most of the time facilities they'll have a big bag of fluid and we will kind of preload your body with a bunch of fluid. Again, that is something that we kind of do to prepare the body for that possible drop in blood pressure. We're kind of filling up the tank, as you will. Then usually anesthesia will come in with a little cart. I feel like everywhere I've kind of been, there's like a little anesthesia epidural cart, and we'll come in and we're all ready to go. And we'll talk to you, and you're huffing and puffing and ready for that epidural by the time we walk in. And what we'll do is we kind of have you, position is everything. Luckily, with laboring women, your back is a lot more flexible than when we do neuraxial on older people, like spinals for ortho, etc. So the spinal cord is really nice and kind of flexible compared to the older generation that I work with as well. And so we have you kind of hug a pillow and you'll kind of sit with either your nurse or your support person, depends on the facility. And that could be a good question as well now that I'm talking about it, is ask if your facility that you're delivering at allows your support person in the room during an epidural. That is something that I feel like is very facility dependent and also possibly anesthesia provider dependent. There are some providers that don't let, that support person be in the room. There are some that don't care. So just something that, I don't want you to be surprised when you're there and then all of a sudden they take away your support person and then you start to freak out. So it's something that you might want to know prior to going in if you're planning on having an epidural. Once that is all sorted out, you're going to get into position, and I always like to say it's like a mad Halloween cat or like a shrimp. You're going to grab your pillow, you're going to kind of bend over, hug that pillow, bring your chin to your chest, and you're going to drop those shoulders. And basically, it's like the worst posture that you can have. What that does for us is that it opens up those inner spaces, and so we can get as much room to get that catheter through those inner spaces and into the epidural space. So once we're in position, I'm going to feel the top of your hips for that perfect level that I inject basically everybody at. I feel the top of the hips, and you'll kind of feel us make a little mark in your back. That's just kind of marking that that's that spot before we clean it because we got to keep it sterile, right? So we'll kind of mark that spot there. After I have my little mark on your back, then I'm going to start setting up my kit. I'm going to say, I'm not going to poke you until the setup takes longer than the epidural process itself most of the time. Then I'm going to start to open my kit. It's all sterile, so that does take a little bit of time. Once I get everything set up, I'm going to go ahead and I'm going to grab some cleaning solution, and it's going to be cold and scratchy. We're going to clean that off on your back. After that, I'm going to give you some numbing medication, some lidocaine. Typically, that's the worst part of the whole thing. Some people don't even feel it. I couldn't even tell you. I don't even remember getting the numbing medication. I was in so much pain. And some people, it's like a little bee sting. So it totally depends on the person. But after that, you should just feel pressure. You should not feel anything sharp. If you do say something, advocate for yourself. We can always give, there's a ton of numbing medication in that kit. So we can give you more if you need it. No problem. It's just like getting a tooth pulled. It's the same thing. Like ask for more medication. No problem. So after that, we'll get that epidural needle. And this is the one that everybody kind of freaks out about, but you're not going to feel it, so it's fine. We go in there and we feel through different layers of the spine. Basically, I'm going to keep this really broad. We go in and we basically do it based off of pressure until we lose pressure with our syringe. That's how we know we're in that epidural space. Once we lose that pressure, we know that we're not up against any muscle or ligament anymore. We've lost that resistance of our little loss of resistance syringe. And we go ahead, we're like, perfect. We'll grab our catheter, we thread it through that needle. Once we're in, we pull that needle out so the needle does not stay in the back. I feel like that's a very common myth. Needle is not staying in your back. It is just a soft, flexible little tube that we eventually hook up and put some medication in, and you're comfortable in like 15 minutes.
That is awesome. Okay, how long does that whole process take from us cleaning your back? Or actually, let's back up to the very initial mark all the way to you've pulled out everything but that catheter and now we're taping you up.
I'd say It totally depends, and I don't want to give a time that gives somebody false hope if somebody's a little bit slower, but
Yeah.
I'd say this could take 5 to 10 minutes.
So it's quick.
It's very quick.
Yeah.
Yeah.
Okay, and then you're saying like within 15 or so minutes after that, that
Yeah.
initial dose, you should be feeling some relief, some comfort.
Yes. Yeah.
Nice. Okay,
Yeah.
so it is pretty quick. The longest part is actually sometimes just waiting for the anesthesiologist for your turn in line.
Yes. 100%.
Got it. Okay, now when we're talking about the medications that you're using, talk us through what are you actually putting in our epidural to give us that relief?
Sure. And another time of me saying this is totally facility dependent. Most hospitals they come in these pre-made cassettes that you
Okay.
can basically just take this cassette and put it into this epidural infusion pump. The places that I've worked, I've only ever seen ropivacaine as the numbing medication agent, and then usually there's a little bit of fentanyl in that medication as well. So it's usually a mixture of local anesthetic and an opioid.
Is there any sort of accommodation or special, I guess, recipe for anyone who might come in with any sort of history of substance use or abuse, or someone who is in recovery and maybe worried about the impacts of that after they have been recovered for quite some time?
That's a great question. Yeah, like there have been times where I've needed to just draw up ropivacaine and make my own bag. So that's definitely possible. Anesthesia, we do stuff all the time that's not the norm. We kind of mix and
Yeah.
match. We're little mixologists. So ropivacaine also does come in like a big glass vial that we would just probably draw that up and put it in a little baggie, and then we can eliminate the opioid as well.
That's really nice. Okay, and the whole time that you have your epidural going, it's coming from a drip bag that looks like or similar to like the saline solution or the lactated ringers. Are the lactated ringers going the entire time? So are we getting both fluids and the medication at the same time? I'm asking this for people who are worried about like, being pumped too full of maybe some fluids, especially if they're hydrating orally, even with an epidural.
Oh, sure. So you're talking about like the IV fluid? Okay. Usually I know they try and get that whole bag of fluid in prior to the epidural.
Okay.
Um, I'm not sure. I think again, this would be facility dependent. If they continue on a current drip of fluid while the epidural is going in, I can see that being a thing because, the possible drop in blood pressure, etc. I can see no problem if somebody felt like it was starting to be too much that you could just turn that off. I mean, in all reality, like 1 liter of fluid's really not going to do big things for your blood pressure changes, and especially in a pregnant woman, there's so much fluid already. So,
Yeah.
yeah, but the epidural itself, we set it to a set rate, and again, that's going to be provider dependent on where they kind of like to sit in regards to like mLs an hour. And since we're on the topic of that, I think it's really important to note that you can really advocate for yourself and the kind of epidural that you want in a way. So for me, I knew that I could have a low rate. I actually wanted to have my baby naturally. My labor ended up being kind of like a hot mess and was the opposite of every aspect of my birth plan, unfortunately. I'm pretty crunchy and I wanted to go all natural, and I ended up with preeclampsia, ended up on max dose Pitocin. I was doing all these things, ended up with a C-section. So things, he got stuck, like it was a whole thing. But I had had that conversation with myself, and that, no hard feelings if I get an epidural. If things go a certain direction, I am not going to be mad at myself for choosing the epidural. And that was kind of how it ended up going. So have that conversation with yourself going in as well. But basically, the rate of that epidural can kind of control how much you feel as well. And so I knew that I wanted to be able to feel as much as I could. Unfortunately, Pitocin contractions are really uncomfortable. And I was on a crazy dose of that. So my contractions were like out of this world. So I was able to kind of eliminate the contraction pain with my epidural, but I was able to completely turn myself in bed. I was lifting my legs up on my own. It was a really nice way to kind of be able to participate in my delivery a little bit better and have some sort of control than to just be completely flaccid, which is fine too, because there are a lot of women that just want to be like, nope,
Yeah,
I
I
don't
don't
want
want to feel a thing. So is this
that's fine
something
too.
that you're having? That's a discussion that you would be having with the anesthesiologist before they place your epidural. This isn't really something that you're talking to your OBGYN about because they're not placing your epidural,
Oh,
right? It's
yeah.
when they come in to talk to you about what's going to happen. You say, it's very important to me that I have a low dose, or at least we start at a low dose. That way I can still have some leg control and stuff like that. Yeah.
Yep, exactly. And for me, I know most places do this, not everywhere, but if you do, you might be given like a little button. And so then you can get additional doses if you want to stay at that low rate. So for me, it was kind of nice to stay at that low rate. I had a lot of control. And then when I was pushing in a certain position that was really uncomfortable, I could give myself what they call like a bolus dose from that button and then get through that contraction, get through that position that I was pushing in and then let that kind of wear off a little bit, go back to my rate. So I know most women they end up with a button like that, which is kind of nice too to stay at that lower rate and then give yourself additional medication if you need it.
Yeah, so listeners, what Marissa's talking about is a PCA, a patient controlled administration button, and it actually looks like a Jeopardy buzzer. It's like this handheld thing, and it has usually a button on top. And Marissa, when you press that, how much medication is coming out, and in what time can we expect to see those effects? And how long will it be in our system before it kind of wears off, and we'll be kind of thinking about if I need to press the button again?
Okay. Again, provider dependent. So usually they'll go in, they'll pick a certain amount of ml that they can kind of give through that catheter. Usually you can expect that to kick in. Again, it depends. I'd say maybe 10 minutes plus or
Okay.
minus 5 for that little bit of an extra dose. I'd say maybe 5 to 15 minutes that you'll feel that. For me, I felt like it was pretty quick. It's important to say, I think that every woman processes medication completely differently. So my metabolism is going to be different from somebody else's metabolism. So maybe I processed mine really quickly. Somebody else, it might linger for quite a bit. The same goes for when that epidural comes out. You might get some sensation and movement back really quickly. Other women, it could take hours. So it does really, really depend for sure.
That's amazing. Okay, let's get real. Dressing your postpartum body is a whole situation. You want to feel put together, but also like not wear jeans. You want to be comfortable, but not the ratty tatty sweatpants from college that have holes in them and the drawstring is so frayed that you could literally French braid it. Hey, I know. And you need something that can handle the spit up, the leaking, the marathon cuddle sessions. I get it. That's where Cozy Earth's bamboo jogger sets come in. These have honestly been my new mom uniform, and I do not say that lightly. These joggers are ultra soft, like wrap me in a cloud and don't talk to me type of soft. They have got a relaxed fit that is just enough shape to like feel intentional, and it's made out of bamboo. So the fabric, it stretches and moves with my postpartum body, which obviously is a must. I nurse in mine, nap in mine, and still feel super confident leaving the house in them too. I feel like I can really take on the world in these jogger sets, and the spit up stains just serve as a little extra go-go juice. Plus, they wash like a dream. There's no fading, there's no pilling, there's no shrinking, thank goodness. Just the same soft, cozy magic again and again and again. I've literally worn them on Zoom meetings, and no one even knew it was loungewear. And honestly, that is the kind of energy I need in my life right now when I am in this newborn bubble. Now, pair these joggers with their amazing bamboo sets. Voila, pure perfection. The gift that makes your sleep even better. These sheets are crafted from viscose, from bamboo, so they are super soft, just like the jogger sets. I'm telling you, when I am talking about like soft luxury, getting cozy and postpartum, this is exactly what I mean. Not only are these the softest sheets I've literally ever felt in my life, but they help you from overheating. They help you sleep several degrees cooler. They're perfect for snuggling on winter nights and waking refreshed for the holiday mornings ahead. So, if you are like me, living in that weird space between comfort and chaos, you deserve a wardrobe that does both. And trust me, this is the set that you'll be reaching for daily. Not only the joggers, but also the sheets. And right now, you can stack my code HEHE, HEHE, on top of their site-wide sale, giving you up to 40% off to grab your new favorite postpartum uniform at CozyEarth.com. And don't forget the softest sheets ever, because becoming a mom doesn't mean giving up style. It literally just means upgrading intentionally to be cozy, comfy, but stylish. These deals won't last long, so start your holiday shopping right now. One more time, visit CozyEarth.com and save up to 40% off using the code HEHE. That's nearly half off the comfort that your body and soul are craving right now. Because you're not just a new mom, you're a queen in recovery, baby, and Cozy Earth gets that. Okay, and I have a question about eating and drinking with an epidural. So, obviously, it's very well known that we should eat and drink in labor. This is traditionally thought about with unmedicated labors. With epidural births, it's commonly told to us that we can't eat and drink. But from my understanding, the anesthesiology world has kind of thought that maybe we can let people eat. What's the data actually really say about this?
Okay, in my opinion, the risk is we're worried about aspiration, right?
Okay.
And so the risk of putting in the epidural is getting that possible high epidural, that high block into where we could have some respiratory issues. Obviously, the risk of that is extremely low. And so with us, anesthesia, we just don't like anybody eating or drinking. So I think just OB in general, we're just like, oh, like these people aren't having surgery necessarily, like, but they're like moving and they're eating and they're drinking water because they're staying hydrated. And like you said, this is so important in labor. So this is going to be again provider dependent, but and they're also worried, I guess, if you had to, progress to a C-section, then okay, if that goes emergently, then we have to intubate you, then you've got a full stomach. In my opinion, all pregnant women are considered an RSI, which is a rapid sequence induction. That means that when we put you to sleep, we're not using a bag to put you to sleep because you're considered a full stomach as a pregnant woman in general, every pregnant woman, because of that weight on your belly, because you have delayed gastric emptying. So every woman, if we do have to put you to sleep, we are putting you to sleep in the same way that we would emergently put someone to sleep. Just like a trauma, if you were to come in from a car accident, we're treating you like you have a stomach full of in and out. Like we don't want anything bad to happen to where that food can come up and possibly cause aspiration. So that is the risk. In my opinion, and again, this is going to be hospital dependent. Some might have a strict policy versus what I have to say. But I do believe that nutrition during labor is extremely important.
Yeah, I mean, your uterus is a muscle and we do want to be
Yes.
able to fuel your body. I would say too, there's ways to kind of accommodate this policy and reduce that risk while also nourishing your body. So maybe you think about something like applesauce or some light trail mix versus like chowing down on a burger or a whole pizza. So that's something that we teach our clients inside the birth lounge is like, if you get an epidural and you really feel hungry and you've come to the decision that you want to eat, just be mindful about what you're eating. And then I'm telling you guys, please don't lie to your hospital staff. Do not lie to them and say, no, no, I haven't eaten anything. It is just incredibly important that you're honest with them. You have the right to eat. That is literally your right. So just do it confidently and then be very transparent and honest with your hospital staff about, like, yes, I am eating. I wanted you to know. I want it to be in my chart, because the worst thing that we can do is hide things from our medical providers and then it cause a complication down the road. And it could have been prevented if we had been honest.
100%. And this makes me laugh because you do black out so much in labor, I feel like, but this just came back to me is that I was about to go to my C-section and I think I was drinking or eating something and my midwife walked in and she was like, Marissa. And I was like, yeah, no, I know. Like, I'm not supposed to be doing this. And she
Doing
was
it
like,
anyway.
okay. She's like, okay, at least you know. And I was like, oh, I know. I was like, anyways, let's go.
Take me back. That's hilarious. Okay,
I'm
I want to
thirsty.
circle back. I want to circle back to the idea of why would an anesthesiologist not want a partner to stay in the room when we know that it will reduce anxiety for that mom and it could possibly be a preventative measure against birth trauma? Help us understand that because I think as consumers, that can feel kind of icky. It feels like maybe that anesthesiologist is trying to control an environment at the expense of our experience or at the expense of that mom. So I'd love to kind of level set and hear like what is that? Where is that coming from?
So there's two main reasons that I feel like people don't want people in the room. Number one is the argument will be like sterility. We don't want any excess. Placing an epidural is a sterile procedure. We will put most places will put a little like bonnet on your hair so
Okay.
hair isn't falling in the back. I'm wearing a mask. Sometimes they'll even make the patient wear a mask. The nurse is wearing a mask sometimes. So one of the biggest arguments would be just keeping less people in there. It's like a quote operating room. We want to keep it really sterile just to minimize that risk of infection with the epidural placement. The other reason is because I have heard of there being legal issues with the partners passing out during epidural placement. I have heard of men passing out when they see the needle hitting their head. Now the dad is in the ER with a head injury. Mom is freaking out because now her husband's downstairs. And so I think that those kind of stories have circulated in the anesthesia community. And now I'm just like, oh crap, like, I don't want to I don't want to deal with that. And unfortunately, anesthesia is always thinking about legal risk and we hear those stories and we're like, nope, I don't want any part of that. Like, I will say it was very nice having my husband there for me. I would have been okay not having him there, but I understand that epidurals are scary for probably most people. They don't see them like I do. And it is really important to have your support person there. So that is a great question to ask, like I said previously, to make sure that you're going into it, okay, I'm gonna have to be by myself if I get an epidural. Like I mentally need to process that versus being like shocked and then having a freak out moment while you're contracting, while you're in a ton of pain, you know, just
Yeah.
planning is everything.
Or it may come down to you guys having a conversation with that anesthesiologist and saying, like, my husband is willing to put on whatever garb and protective gear you
Yeah.
want him to wear. He's happy to sit in front of me so that he doesn't see the needle. He won't get
Yep.
up out of the chair so you can keep the environment sterile as possible. But I really can't do this without my partner here in front of me. I think that, a lot of times it's presented as like an absolute, and there's definitely flexibility if you will just kind of level set with your anesthesiologist and have a really transparent conversations about your expectation and your whys and really why it's important to you that your partner gets to stay. Yeah, I could not imagine getting an epidural without my husband by my side. I would not be well. And that's coming from someone who I've been in
Huh?
I've been a doula for 10 years. I've been doing this. I have seen so many epidurals placed. I've actually had the opportunity with really great anesthesiologists that will let me kind of stand behind them. I do have to put on the head stuff and the mask, and I stand and usually they're like stand on that tile, don't move. But they've let me watch, and it has just I feel for me made me a better doula. I'm able to answer questions for my clients. I'm able to explain things. And when I am that support person in front of them, I'm able to give them kind of a play by play of what they're feeling, what's going on. When they have anxiety, I'm able to let them know from experience, like, you're safe. Here's what you're feeling. This is what they're doing. We're almost done. And so, yeah, don't be afraid to advocate for yourself and say like it would really help me feel so much safer if my partner got to come and be here with me and we're happy to like follow the rules or follow the procedures or have him sit or whatever. So that was really helpful. I think a lot of times online it can feel very us versus them.
Mhm.
And so sometimes we hear what goes down in labor and delivery rooms, and it can feel like, well, that was a bad anesthesiologist. And it's like, well, they have their reasons too, but it doesn't mean it's an absolute. So super helpful. Thank you very much for that.
Of course.
Okay, my next question is, and we've kind of touched on this, but we have the ability to titrate the epidural. So if it's too high, we can turn it down. If it's not high enough, you can turn it up. Tell us about that.
Yeah, I mean, I think people just don't know that that's possible. So, like, I had even talked to my friend after my epidural. She was due like a month after me, and I told her, I was like, advocate for yourself. I'm like, you can have a lower rate epidural. I think people just don't know that they can simply ask their provider to turn it down. It takes us literally 2 seconds. So just kind of keep that in mind. And if you want it turned up, then you can do that too. There are a lot of women that want it, like they do not want to feel a thing, and that is totally fine. It's your birth. You can do whatever you want. So just don't forget that you do have a lot of control, even when you feel like you're almost giving up an aspect of control in that way with the epidural.
And what
Yeah.
about turning it off, especially for women who get it? And I mean, albeit this is very rare, but for the off chance that you get it and then you decide like, I regret this. I don't think I want this. I would like to go back to not having the epidural. Can we turn it off once it's placed?
Yeah. I actually know, I feel like you're refreshing my memory on a story that somebody did that. They placed it and then they're like, I just want it there for like the end if I need it.
Yeah.
They just turned it off and then at least they weren't panicked when, they got to possibly, 9, 10 centimeters and all of a sudden it's like game time and you're like, okay, never mind. Let's turn that thing back on. And we can give you a little bolus dose from that to get the medication on a little bit quicker. But again, and this is kind of making me think of another topic is you'll hear a lot of, there's only a certain time that you can get an epidural. That is very dated practice.
Oh,
There are a lot of people that are like, you got to wait until you're in, the second stage of labor and you can't have it in the third stage of labor because you're too far gone. That is not true at all. You can get it the second you walk in, and you can get it, the second before the baby's going to come out if you can last that long. So another thing to advocate for yourself as well, if you want to wait a little bit and maybe they're trying to push you in due to scheduling, like I had kind of talked on earlier. Maybe there's a C-section coming up and they're like, let's just do it now, but you're only maybe 2 centimeters, feel free to wait a little bit longer, but just know that you might have, there's, the fluid that has to go in, the talk, the conversation, the signing of the papers, etc.
yeah,
Yeah, so
that
you
wait
can
time.
really, you can have an epidural basically whenever you want. And everyone's pain is completely different. Like I walked into the hospital and I was 4 centimeters and I had no pain. And there are some people that are getting epidurals way before 4 centimeters. So that's another thing is don't compare your labor pain to anybody else's. Like everybody's body is so, so different. Don't go into it and be like, well, my friend, she waited until she was 5 centimeters for her epidural. Like, I want to try and make it 5 centimeters. Like, who cares? Get the epidural when you want to get it. If you want to push it off a little bit longer, fine, but do not compare your labor to anybody else's because it is so unique to everybody.
Okay, I love that, but it does bring up the question of the quote unquote right time to get it because of this idea that it slows down your labor. What can you tell us about that?
Sure. Okay, that is, I feel like, such a common, I guess, misconception, and there's two schools of thought on that. So I have heard of women that get their epidural and it actually sped up their labor, and here's why. So there are some women that they kind of go into this fight or flight mode when they're in that much pain, and the hormone that progresses labor is oxytocin. That is that's the reason we inject like it's synthetic oxytocin, Pitocin. It is literally the labor hormone. And so when you're so panicked, you're so fight or flight, you're having so much pain, labor might not progress. And so I've heard of women, they get their epidural and all of a sudden they just dilate like crazy. So there's that side of it. But then there's also the side of, oh, well, it actually prolongs labor. And here's why, in my opinion. Per school, per Google, per the studies, there is no evidence that show that epidurals directly delay labor. Here is how I feel like it could be portrayed that it would prolong labor. So once you get your epidural, you're basically confined to your bed. You're getting a catheter in to drain your urine. You're going to be on monitoring for the most part, unless you push to not be doing continuous fetal monitoring. And so you're not moving as much. And movement really does, as you know, progress labor in a way. And so when you're getting that epidural, I feel like that lack of movement, you're more relaxed, you're not, trying different positions to get baby to descend. That I feel like is where you could somehow make the argument that it does delay labor.
And maybe just a longer pushing time because you're not able to feel exactly what you're pushing into, where someone who's unmedicated would be able to do that.
Sure, and I think that could probably be dose dependent as well. Like for me, I was able to totally feel my contractions. So I was telling my midwife, I was like, okay, I was like, that's one, right? And she's like, yep. I was like, okay, go. So it doesn't mean that you won't be able to push necessarily, because I do think a lot of people do have that fear, but it is kind of a weird sensation that you have to be prepared for, that if you're on a really high dose, high rate epidural, like you might not have those sensations as much. And it might be a little bit weird for you to just be told to push and you're like, I can't feel anything. It doesn't mean that your body necessarily isn't pushing. It's just going to feel completely different.
Yeah. Okay. Now you brought up something just now that is so interesting. And it's something that I have taught for, well, 10 years now that if you get an epidural, you will be subjected to continuous fetal monitoring. But you just said that maybe there are some cases where you advocate not to have that. Talk us through what that decision looks like and what kind of risk are you taking on by declining continuous fetal monitoring, and maybe what are the benefits that you're taking on?
So again, I think for me, like that was something that I did early on. I believe it was before my epidural because I wanted to get up and move. But unfortunately, I feel like, especially in the US, there is such a standard that it's the same thing for every patient. You go in, you get hooked up, you end up somehow confined to the bed. Movement isn't encouraged a whole lot. You got to ask for a birthing ball. You got to ask to have a room with a bathtub in it. Like that was all things that I went in and I knew that I wanted. But unfortunately, I feel like it's not just a given. I had to ask, for certain positions, what if my midwife wasn't in the room? They weren't really being suggested to me. So just kind of going in and having that plan, like, okay, like I'm going to advocate for myself here. I am going to have maybe a more of a non-traditional birth. And unfortunately, I feel like the if you don't do that, you're going to have the standard, okay, here's your fetal monitor. We're going to have your blood pressure cuff. You're going to be confined to the bed. We're going to take your vitals, and then you're just stuck, and then you're just not moving. you know?
Yeah,
Um,
so it is possible that you ask for intermittent fetal monitoring with an epidural.
in my opinion, yeah. I don't think there's a need to be continuous. I mean, I think it's important to like spot check. Again, that's going to be what the OB/midwife or anesthesia provider is comfortable with. But I do agree that it's important to kind of, reposition yourself, move around. But that is one of, I guess a con in regards to an epidural is that you are pretty much limited to staying in bed.
Yeah. Now, do we see any sort of correlation or association between epidural use and like funky fetal heart tones?
No.
Yeah. Okay.
And
And then what about the medication transferring through the placenta and getting to your baby?
yeah. So another really common question, the medication that gets transmitted to baby is so, so low. Is there a very, very small amount that does get to baby? Yes. Anything that you give to mom is basically going to get to the baby.
Okay.
The thing about epidurals is that catheter just stays in that epidural space, and so does the medicine. So it basically just kind of floats around and diffuses to that spinal cord, and that's how you're getting that medication. But it does really just kind of stay there. Obviously, a little bit is going to diffuse out, and that's the small amount that gets to baby, but it's definitely not a large amount enough to have any side effects to the baby that are significant.
So, what would that look like if it did impact baby? Maybe some grogginess at birth or respiratory stuff?
Yep. I
Okay.
mean, you do hear of cases obviously like that, and who knows if there was anything else. I mean, that could be a perfusion issue. Was the mom hypotensive
Okay.
for a while? There's so many different things. But yeah, you do hear of babies that come out a little bit more sleepy. Not a big deal. Anesthesia is there for a reason, and we can, intervene if we need to. But
Okay.
I wouldn't say, and I'm pretty crunchy, like I said, I wouldn't say that if you're worried about any medication going to baby, I wouldn't make that the reason if you're on the fence about an epidural to decide yes or no, because it is so, so small.
Yeah. So,
Shouldn't
all of this rhetoric online of don't get the epidural because your baby's going to be like getting fentanyl in birth is kind of fear based.
Yes.
Yeah,
Yeah.
that's
Very,
good to
very
know.
low.
Okay, good to know. And then when you're debriefing someone on well, I guess not debriefing, when you are explaining risk and benefits before an epidural placement, what kind of things are you sharing with them?
So risk and obviously benefits we've talked about a lot. Risks, risk of infection anytime anything enters
Okay.
the body, any puncture, even your IV, there's an infection risk from just something being in there that shouldn't be in there. Bleeding risk is very, very low, but there are blood vessels around there that we could possibly hit. That's one of the reasons why we do a little test dose before we start your epidural to make sure that we're not in a blood vessel. You know, risk of, I guess, even itching sometimes from the narcotic in there. Some people are really sensitive to that. They can get itchy from the possible fentanyl in there, shivering as well, and then very, very low risk of paralysis. I think it's 1 in a million.
And that literally 1 in a million. And then that risk of your blood pressure drop and the feeling
Yep.
that you can't breathe, but not actual respiratory distress, or
Yes.
yes, is respiratory distress like a very low risk as well?
I'd say it's a very, very low risk. So there is a risk of that medication possibly being in the wrong spot, and that's another risk as well, as if we go a little bit too far and we go where we insert a spinal. And so that needle can sometimes, if we go too far, that's a very low risk as well, but you'll hear the risk of a severe headache after, and that's from a post-dural puncture headache where the provider went a little bit too far and that big needle causes a hole in the dura and it can cause a little bit of a CSF leak, which can cause a severe headache. I think it's a 1% risk or something like that. It does happen, and there is a bunch of treatments for that. So, again, I wouldn't make that something that convinces you otherwise. But yeah, it's a medical procedure. There's always risks with any of that, but
Yeah.
epidurals are extremely safe procedures.
Especially because they're done so often. And when you say CSF leak, it's just a little bit of spinal fluid leaking out.
Mhm.
Is that right?
Yes.
Yeah.
Yep. Some people
And
say.
then what would be the remedies if you did have that post-dural headache?
So usually, and you'll know it, like you'll walk into these rooms, like the lights are off, you can't even sit up, like the people are like lying flat in bed. Usually their eyes are covered. It's excruciating to even sit up. It's pretty horrible headache. And it can last for a couple of days. And so usually we'll start with something even like caffeine. We can give caffeine and that can help vasoconstrict those vessels and kind of help with that headache. But what we can also do is it's another epidural, which seems kind of counterproductive. But what we do is it's called a blood patch, and we draw your own blood sterilely and we inject it back into the epidural space. And what that does is it literally makes a clot on that hole and it kind of fills that space and puts some pressure on where that leak is and it stops it. And they work
Wow.
really well.
Okay, and if you don't get that, I assume that the little puncture wound will just kind of naturally
It
kind of
can. Yep.
almost scab over without being a scab, and kind of just regenerate itself.
Yeah. Some can definitely resolve on its own.
Okay, cool. Okay, and now you mentioned a spinal. What's the difference between an epidural and a spinal, and when would someone want to request a spinal over a traditional epidural?
It's a good question because I feel like I see a lot of people saying they've had spinals for labor and all this kind of stuff, and I feel like there's a lot of confusion over that. So you're not going to get a spinal if you're in the labor and delivery room. That is something that we do for C-sections. There is something called a combined like spinal epidural, which some providers will do, and that's going to be completely provider dependent if that's a technique that they like to do. But basically, we just go a little bit further into that, I'll call it the spinal canal, the spinal area, and we go a little bit further and we puncture the dura where we're basically in this sac of fluid where the spinal cord actually is. And so it's a lower dose of medication because we're directly right there. And so with the spinal, we don't actually thread a catheter in. We are just directly at the spot that pain medication needs to be. The epidural, when we do it, it works by diffusion and it kind of like slowly, gradually gets to that area. Whereas a spinal, we're just directly there. They work almost immediately. It's a smaller volume, and that's what we typically reserve for C-sections. And then with that, you'll go numb almost instantly from that waist down. It's the same placement technique, other than we're not threading a catheter essentially, and there's a little bit of different needles.
And
Yeah.
does it wear off quicker since it is a smaller dose of medication?
Um, Yes and no. I feel like spinals can typically last, maybe when I inject it, maybe I'd say an average like an hour and a half, 2 hours. Versus an epidural, it's a little bit slower, but it's been on for a while, so that could take, a couple of hours sometimes too. I guess like I said, it is totally dependent.
Yeah. Okay. And then because you're right in that spinal space, does a spinal carry any additional risk of either paralysis or that long-term back pain?
No. So it is the exact same technique. We're feeling the hips, we're injecting that needle in the same location. We're not going anywhere higher. You will sometimes feel like zingers as we're in there because your spinal cord has almost like little strings that kind of come off the bottom of it. And so we can sometimes kind of, this says it nicely, like tickle those those strings that kind of come down, and people will be like, "Whoa, okay, I felt it. I felt it." And then you're like, "All right, I'm there." It's a very weird sensation. I didn't feel that. I didn't have a spinal. What's nice is since we're talking about it, is if you have that epidural already placed and you did need to go to a C-section, we can dose that epidural for your C-section. So we just give a little bit more medication and then it's super easy. Then we're already covered and we don't have to give you a spinal.
That is super nice. Okay, and in terms of removing the epidural, can you talk us through what that procedure looks like? And I know you said a couple of hours, but on average, how long until our feeling kind of returns? And then what? Are we good to just like get up and walk around? Can we just expect our bladder, function to kind of come right back? What does that look like?
Pulling the epidural is super, super easy. I think people freak out about that. Like, I don't even remember mine coming out. Like, literally, all we do is we just take the tape off and we just pull that catheter out. It's like, it's so easy. You're not even going to feel it. It's a very simple procedure. Usually, we're going to wait once you can kind of get your movement back. You can kind of lift your legs up a little bit. Bladder control is really kind of interesting because everyone is different in that regard as well. We want to make sure that you can at least stand up without help and make your way to the bathroom. A lot of hospitals, I'm not really sure in regards to that's going to be like very policy dependent, I guess, on when you're allowed to. And maybe you would probably know more about this than I do because I kind of just put the catheter in and walk out. But I don't know in regards to when hospitals allow you to get up after an epidural. I would probably guess like at least a couple of hours just for safety reasons so you don't fall. Obviously our biggest risk is, you think that you can maybe move a little bit and then you go to stand up and then you're just nope, I'm still a little bit numb. So I can see hospitals maybe at least waiting 2 hours. I'm totally making that number up though. It's going to be hospital dependent.
Yeah, just making sure that you're actually good to be weight bearing on your leg
Yes.
after
Yeah.
having that anesthesia. So, is your nurse or your OBGYN pulling out your catheter, or is the anesthesiologist coming back to remove the epidural catheter?
I believe most hospitals they have the nurse.
Oh,
Hmm.
well, okay. Yeah. Very
Yeah.
convenient.
Yep. Yeah. So they're already there with
Cool.
you. Basically, once baby comes out, they're like, okay.
And then my last question about the placement is what do we need to know about being cathetered for our bladder, for like urine catheter, since we won't have that bladder control?
What is really nice, I mean, for me, honestly, I was so relieved to get that Foley catheter because I don't know what it was. Like I was peeing like every hour the second I got into the hospital, and I was just like, "Oh my gosh, like I'm hooked up to everything. I've got like my magnesium drip, which obviously with the preeclampsia stuff, it's a little bit different than everyone's traditional birth, but I was having to get up like every hour. And then finally, when I caved for the epidural, I was like, you know what? Thank God this catheter is going in because I am so tired of getting up every hour. This baby just needs to come out. But yeah, so basically, anything from that level of injection, we're blocking those impulses. So your body is not going to feel that you have a full bladder. It's just not. And so that is the reason that we have to put in a Foley catheter. So again, that's something to kind of keep in mind. And I think a lot of people get surprised about is they're like, wait, what are you going to do right now? So we do insert a Foley catheter into your urethra and into the bladder, and it will be there until the epidural comes out. But it ends up being kind of nice because you are not getting out of bed. So
I always find this so interesting because in my experience it is different from like facility to facility
yes.
because the risk of infection with a straight cath, which for listeners that means we put it in, we drain your bladder, and we pull it out is much lower than a continuous catheter, which they typically will place and then they'll tape it to your leg. So if you find that it's uncomfortable, although you shouldn't be able to feel it, or you just have, you have concerns about risk of infection, feel free to have a conversation with typically your nurse, but it could be with your midwife or your OBGYN or the whole staff, your whole care team about if you have a preference for straight cath versus continuous cath. You do have some options there, but each hospital policy will have obviously what they prefer as well. So that's always just so interesting when they are still using continuous catheters. And I'm always like, why, when we know that the risk of infection is so much less with a straight cath, just like cath them and come back. But do recognize that with a continuous cath, it's one time procedure. You put it in, you tape it, you're done. With a straight cath, we are emptying your bladder every couple hours because a full bladder will hold up your baby. It causes additional risk for postpartum hemorrhage. We know that it can make your contractions a little bit inefficient. So, risk and benefits to each of those decisions. But I always am just very sure to remind people that you do have choices around that. Okay, Marissa, this has been an awesome conversation. I have one last question, and it
Okay.
is more it's more emotional, physical, more emotional, spiritual. But for women who get the epidural and it wasn't their plan and they feel like a failure, they are feeling guilt and they're feeling shame and they're feeling like I should have, that shitty should have, I
Mhm.
should have been able to do it without. What do you have to say to them?
I feel like that's so important. And I've actually done a ton of research on like the mental aspects of epidurals. I actually did like a year-long research project on that
Wow.
and found that in regards to having an epidural or not, there wasn't anything statistically significant in the outcomes of the birth. But the biggest thing was how women portrayed their birth emotionally. And so just keep this in mind when you're deciding whether or not you're going to have an epidural. How are you okay, with your birth? So are you going to be okay being possibly exhausted, being up for a long time, being sweaty, being, not your best self, going through that naturally, which again, nothing against it because that was something I wanted to do. Is that something that you're okay with? And then when your baby comes out, are you okay with meeting your baby for the first time exhausted? Or are you wanting a different type of labor to where your baby comes out and you're feeling refreshed and you had time to put makeup on and you're feeling great and there's all that kind of stuff. It's two very different births and both of them are completely okay, but that was the biggest thing is, the women that did it naturally, they were almost like I was so exhausted. I felt like I didn't even treasure meeting my baby because I was just like so relieved that it was out and then I was just catching my breath the whole time. And then there was the other group of women that, they almost regretted it because they kind of put themselves first in that way. So there's a lot of different perceptions, like you kind of said. So really, this is your birth, and your birth is not going to look like your best friends, your coworkers, your bosses. It doesn't matter. It's very customizable to an extent for yourself. So do what makes you feel good. I ended up having the epidural and I put some makeup on before my delivery. And that wasn't what I thought I was going to do. I wanted to kind of rough it a little bit and get in the tub and do this water birth and all of this thing. And it just totally didn't turn out to be like that. And that's okay. I still do kind of deal with a little bit of like, I wish I could have, felt that a little bit more naturally and stuff like that. And I think that's normal. And that means you care about your baby, you care about, your birth. It's a big deal to give birth. It's one of the biggest days of your life. So don't be so hard on yourself. Epidural is a really, really personal decision, and it's nobody's business whether or not you get an epidural. Like, I know I'm an anesthesia provider, but I firmly am okay with either side of it. It's just something that I do in practice, but I'm a little bit crunchy as well. So I love the whole natural birth thing too.
I love
Make
that
it
so
your
much.
birth. Make it your birth. It is not about anybody else.
Yeah. Oh my gosh. I know that is what so many people out there needed to hear because I do know that there are some big feelings that come along with pivots that we sometimes encounter in labor, especially when they were not our original plan. So that was awesome. Marissa, thank you for being here with us today. I really appreciate this. I think this is the conversation that so many people are eager to have, are seeking, are wanting, are yearning for, but they don't have anyone to ask. And I just want to thank you for being here, holding this space, sharing so transparently so people can have access to this evidence-based information and no judgment. You presented it very eloquently and just I guess really straightforward to say, like, here's what you need to know to make your decision. And I trust you to make that for yourself. And there's no judgment on either side of the fence of whatever you choose. And I think that's a really, really special thing that not every provider possesses. So thank you for sharing that with us today. I really appreciate you. If people wanted to connect with you, learn from you, stay connected, how can they do that and where can they find you?
Sure. I am Sassy Anesthesia on Instagram and TikTok.
I love it so much. You guys, please remember that an epidural is just a tool in your toolbox. It is neutral. It's not good. It's not bad. It does come with risk and benefits. It comes with pros and cons, as does every decision in your pregnancy, in your labor, and in motherhood. You guys, I love hanging out with you every single week. I am so jazzed up to be able to bring you the conversations that you always come to me asking for, but I want to bring you the experts that know way more than I do. So thanks for hanging out with us today. I'll see y'all in the next episode. Be sure to follow Marissa on social media, and you can find me at Tranquility by Hee and at the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I love hanging out with you, and it is an honor to be your go-to gal when it comes to preparing for your baby. If you've enjoyed today's episode, please leave a 5-star review and tell others why they should be listening to the Birth Lounge podcast too. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent without all the trauma that you so commonly hear about on social media. New episodes air every Wednesday and Friday. Hit that follow button so you never miss an episode. I'm Hee, and this is the Birth Lounge Podcast.